40% correct answer, which is not the good percent. Yes, a classical clinical question. 3-week-old, since birth, sleep most of the time. Baby is dull. Awaken every 4 hours. She also concerned persistently hard pellet-like stool. So few have answered Hirschsprung disease. Hold on, read the question further. Normal weight and length, but enlarged head. Heart rate is 80. You find a 3-week 80 means bradycardia. Temperature 96.7, hypothermia. Child is still jaundice. So yeah, it can't be Hirschsprung disease. It can't be sepsis. Bradycardia, hypothermia, constipation, large head. Anterior and posterior fontanelles are open. Distended abdomen, umbilical hernia. What else you want, my friend? Yes, it is classical congenital hypothyroidism. This is clinical question. Just remember this question. Read again and again this question. This is the typical question of congenital hypothyroidism. You should not miss congenital hypothyroidism. Why? Why? It is the most common cause of preventable mental retardation. Yes, if you diagnose it on time, mental retardation can be prevented. And can you imagine 4-5 time questions asked? Ideal time to do neonatal screening for congenital hypothyroidism after 48 hours. After 48 hours. So choices will be just after birth, 24 hours, 7th day, just after 24 hours, third day, it's the ideal time. You need to check TSH. If it is less than 20, your chapter is closed. Baby is not having hypothyroidism. It's, yeah, abhi maternal hormone interfere in first 48 hours. So this they ask, when you would like to do the screening for congenital hypothyroidism after 48 hours, TSH, if less than 20, normal. If more than that, then algorithm start. And what is the most common cause of congenital hypothyroidism? It is thyroid dysgenesis. Thyroid dysgenesis. Yes. So causes can be primary, means problem in thyroid, or secondary, above problem is there. So primary, thyroid dysgenesis, anatomy problem. Thyroid dysharmonogenesis, functional problem. And transient due to maternal antibodies. Yes, you need to remember which is the commonest cause, thyroid dysgenesis, and secondary problem in hypothalamus and pituitary and malformation in the brain. So TSH not secreted, then thyroid stimulating factors not secreted, which leads to secondary hypothyroidism. So just remember this classical history, Now see the features. It's very common: dull face, puffiness of eyes, large tongue, anterior and posterior fontanelle open, rough skin, jaundiced child. So why not? Today we will remember all the features of congenital hypothyroidism. You find facial puffiness, hoarse cry, hypotonia, hypothermia. Read in our question, temperature is 96.7, prolonged jaundice, open posterior fontanelle, rough dry skin, large tongue. Just remember, just read once or listen once, you will be remember these features. Others are distended abdomen, umbilical hernia, constipation, pallor, prolonged sleeping time, and bradycardia. So if you remember few of them in our question, heartbeat is 80, temperature is low, posterior fontanelle open, umbilical hernia, large tongue, distended abdomen. What else you want? This is the typical history of congenital hypothyroidism. So one clinical question today is finished, that is congenital hypothyroidism. With this history, if you read this question twice, it will be in your mind. This is congenital hypothyroidism, most common preventable cause of mental retardation. That's why in all good nursery, they do the screening for hypothyroidism. Third day means after 48 hours, heel prick, take the blood, just 2 drops of blood, and you can diagnose child is having congenital hypothyroidism, yes or no. So just typical history, each and every point. Sometimes we are in free moods. Remember, this is the feature and classical history of congenital hypothyroidism. Yes, something more. Answer this question. 45 seconds is your poll duration. Read, practice. You have to give right answer, either direct or by exclusion. Read carefully. Soumya is right, Harshita is right, Insha is right. Sharat, right. I am getting very few correct answer, my friend. Now, we are here for learning. Na? Don't repress. I will teach you every topic clearly. See, a 2-month-old baby brought to emergency room. She is pale, respiratory distress, respiratory rate 60, heartbeat 195. Height sound are muffled, distant, gallop is heard. With S1, S2, third and fourth heart sound also heard. Gallop, child is in failure. Has cardiomegaly on chest X-ray. Cardiomegaly on chest X-ray. Now see, ECG demonstrate poor ventricular function, echo, poor ventricular function, dilated ventricle, dilatation of left atrium. ECG show ventricular depolarization complexes are low voltage. So it means we are dealing something cardiac problem, cardiomegaly, child is having respiratory distress, which is not explained by respiratory finding or chest X-ray. Cardiomegaly is there. See the choices. That should be your approach. Pericarditis, no. Pericarditis classically have STT changes, which is not given in this picture. So it can't be pericarditis. Aberrant left coronary artery from pulmonary artery, L kappa, which have deep Q wave in ECG, classical, not given. Endocardial fibroelastosis, in which this ventricular lining is more glistening, echogenic, white on echo. So that is also not written. So it can't be. So what we left with? Myocarditis. That should be your approach. This is typical myocarditis. If you work in pediatrics, so many patient distress, heart rate fast, and those distress is not explained by your lung finding. So something wrong in the heart. You do the X-ray, cardiomegaly. Echo, LV function poor. ECG, low voltage complex. It is myocarditis. Now, we read each and every topic clearly. Primary endocardial fibroelastosis. This is a form of dilated cardiomyopathy where diffuse changes seen in endocardium with white, opaque, glistening appearance. This appearance, you can't miss this on echo. White, opaque, glistening, and this is seen in severe obstructive lesion, quarked AS. Now, one question from my side. Mother is having which infection during pregnancy? Baby born with endocardial fibroelastosis. Come on. Mother having which infection during pregnancy? Baby is having endocardial fibroelastosis. I want answer from you. Abhi, Kartika, Walla, Lee, so many good students are there. Please answer. If mother is having Mumps infection during pregnancy, baby born with endocardial fibroelastosis, that is EMF. So this is not there. Then pericarditis. Pericarditis classically ST changes should be seen. So no ST changes mentioned in our ECG. Then it could be Al Kappa. Concentrate. This is the classical question. See, this is aorta. This is aorta. Aorta gave origin to left coronary artery and right coronary artery. Left coronary artery supply the left myocardium, right coronary artery supply the right myocardium. It's okay. Aorta, both coronary artery arises, and coronary artery carries the oxygenated blood, red color. P is pulmonary wall. So normally both coronary artery left and right arises from aorta. This is normal. Now see the second diagram. See the second diagram. Right coronary artery from aorta. What about left? Left coronary artery from pulmonary artery, which will supply the left myocardium. Left coronary artery from pulmonary artery. So this is anomalous. Left coronary artery from pulmonary artery. This is Al Kappa. This is Al Kappa. Now, left myocardium supplied by deoxygenated blood. So what will happen? Myocardial ischemia. MI. Which condition in infant mimic myocardial infarction in adult? Al Kappa. So what are the classical findings, clinical finding of MI? Sudden chest pain, increased sweating, irritability. Yes. What happened in infant? Excessive cry, increased sweating, not able to take feed. Al Kappa. So symptoms and ECG same as MI in adult. This is Al Kappa. Symptoms and ECG same as MI in adults. What are the classical ECG finding? Deep Q wave. Remember, deep Q wave, first AVL V5, V6. Deep Q wave. This is normal Q wave. You can see, na? This is normal Q wave. This is P. First negative deflection after P is Q, then T. This much. Little bit negative deflection. Q is seen in pediatric ECG. If you find this picture, this is P followed by such a deep negative deflection. Crosses 5 small square. That is deep Q. That is deep Q. Yes, this was spotter day before yesterday in DNB final exit exam. This was the spotter. Yes. OSCE, deep Q wave in first AVL. You are seeing now first and AVL. First AVL having deep Q wave. This is Al Kappa, anomalous left coronary artery from pulmonary artery. Al Kappa, sign, symptom, same. ECG same as MI in adults. Al Kappa. So this was not given. Deep Q wave was not given in question. So it can't be Al Kappa. Now see, this is the diagram. You can see both coronary artery arises from aorta. Pure red blood supplying the myocardium. See the second picture. Anomalous left coronary artery. Instead of arising from aorta, it's not arising from aorta. It arises from pulmonary artery. Pulmonary artery carries the impure blood. So what happened? Myocardial ischemia, which gave ECG deep Q waves. So this single clinical question tell you so many things, my friend. This is the beauty of clinical discussion. If I make it one word, deep QA present in which pediatric condition? Al-Kappa. Which pediatrics heart disease mimic MI in adults? Al-Kappa. Now with this question, patients, it can't be pericarditis, no ST changes. It can't be endocardial fibroblastosis, echo showing poor LV function, no glistening appearance in echo scene. Al-Kappa, no Q wave is there. It's the classical history of myocarditis. In COVID time, we are seeing so many patients with this history. MISC, multisystemic inflammatory disease due to COVID. Child presented with myocarditis also. When LV function is decreased, low voltage ECG, tachycardia, pale child brought to emergency in respiratory distress. This is myocarditis. I hope you are clear in the concept of these four cardiac conditions. So congenital hypothyroidism, this question, classical clinical question. Many more to come. Answer this question. 30 seconds is the poll duration. Now, if you know this, you can answer very well. Else, you feel it's a renal disease, so child having acute renal failure. This is the beauty sometimes. If you know this, now edema, oliguria, hypercholesteremia, hypoalbuminemia. What is this? This is nephrotic syndrome, my friend. Nephrotic syndrome. So now examiner want to know which of the following is the major cause of mortality with this condition. Nephrotic syndrome, hypertension never occur. Nephrotic syndrome, hematuria never occur. So this is out. Nephrotic syndrome, prognosis is very good. Child with rarely goes into renal failure. So this is not the possibility. Now, nephrotic syndrome, no chance of heart failure because fluid is not accumulated in the lungs. Fluid is accumulated in the abdomen. Ascites is there. So we are not thinking, yes, nephrotic syndrome, the most common complication of nephrotic syndrome is pneumococcal peritonitis. Patient of nephrotic syndrome is on steroid, so they are immunocompromised. Lot of fluid in the abdomen cavity. Ascites is there, which act as a culture media. Bacterial peritonitis, most common, most lethal complication of nephrotic syndrome. Bacterial peritonitis, which pneumococcal peritonitis. This question comes in another way. Which vaccine you always be sure given to nephrotic syndrome patient? That is pneumococcal vaccine. That is pneumococcal vaccine. We want patient should always have. So this is the major cause of mortality in nephrotic syndrome, bacterial peritonitis. Beauty, na? If you was not there and you are answering renal failure, CHF and hypertension. So this is the new thing for you. And this was AIMS question. Yes, it may come in your exam, like different format. Which vaccine you want to give to nephrotic syndrome patient? Pneumococcal vaccine. Nephrotic syndrome patient commonest complication, bacterial peritonitis. Yes, it is history. It's a nephrotic syndrome. Why it's nephrotic syndrome? Edema, oliguria, hypoalbuminemia, hypercholesteremia. It is nephrotic syndrome. So which of the following is the major cause of mortality with this condition? Which condition? nephrotic syndrome? It is bacterial peritonitis. Answer this question. Very good question. Very good clinical question. And I will tell you so many things in this question. Adolf, Swati, Amit, Durga, Anu, so many good students are there. Now I will teach you real clinical things of jaundice. Now, neonate with jaundice, total bilirubin is 12. Direct is 4.5. When direct is more than 20% of total, more than 20% of total, we call it neonatal cholestasis or direct hyperbilirubinemia. So examiner giving you clearly that direct is 4.5, which is more than 20% of total. Total is 12. What is the 20% of 12? It is 2.5, but direct is 4.5. So yes, it is conjugated hyperbilirubinemia. So what are those causes? Now listen to the basic. This is the basic diagram. See, old RBC, it will take 1 minute. Please concentrate. Old RBCs and iron containing enzymes. Old RBC, when degrade after their half-life, iron containing enzymes, catalase, peroxidase, when they degrade, they liberate hemoglobin. This hemoglobin in the presence of heme oxygenase enzyme convert into biliverdin. This biliverdin in the presence of biliverdin reductase convert into bilirubin. This bilirubin enter into liver. This is unconjugated bilirubin. Now here the things start. Unconjugated bilirubin in the presence of glucuronyl transferase enzyme convert into conjugate bilirubin. Listen carefully. Until unless unconjugate convert into conjugate, it will not able to excrete in the bile duct. It will not able to excrete in the bile duct. So if any problem here in conjugation, conjugate bilirubin not form, so unconjugate will spill in the blood, unconjugated hyperbilirubinemia. Once it convert into conjugate bilirubin, then conjugate bilirubin via bile duct enter into gut. Gut bacteria are there. Those bacteria convert conjugate bilirubin into urobilinogen, which excreted via urine, stercobilinogen, which excreted via stool. This reaction take place in our body every day, every hour, every minute, every second. Old RBC degrade and formation of bilirubin and how bilirubin is excreted. So with this, you are clear, na? So if any problem occur above this line, jaundice is unconjugated. If any problem occur below this line, jaundice is conjugated. Now come to the causes. ABO incompatibility. ABO incompatibility will work here. If mother blood group is O and baby blood group is A, more hemolysis occur. So more RBC destroy. When more RBC destroy, more hemoglobin, more biliverdin, more bilirubin form, which is unconjugated bilirubin. So ABO incompatibility is a cause of unconjugated hyperbilirubinemia. Hypothyroidism, Klegler-Neisser syndrome. Come here. See. CN syndrome, this enzyme is absent. Absent in Klegler-Neisser type 1. This enzyme is absent. When this enzyme is absent, how unconjugate will convert into conjugate? Unconjugate spill, also a cause of unconjugated hyperbilirubinemia. How hypothyroidism jaundice occur? T3 and T4. Normal level is required for maturation of glucuronide transferase. In hypothyroidism, T3 low, T4 low. So what happened? This enzyme not fully maturate. So what happened? When this enzyme is not fully maturated, so unconjugate will not able to convert into conjugate. So hypothyroidism, jaundice, unconjugated hyperbilirubinemia. So ABO incompatibility, unconjugated. Kleggler-Neisser syndrome, unconjugated. Hypothyroidism, unconjugated bilirubinemia. What we left with? Biliary atresia. Very simple to understand. If this is block, this is biliary atresia. Block. So conjugate bilirubin form, but where it go? It is spill into blood. So biliary atresia, we have conjugate hyperbilirubinemia. Conjugate hyperbilirubinemia. One more thing, very good concept. Now see, this is liver. This is unconjugate bilirubin, which convert into conjugate bilirubin. Now there is biliary atresia. This conjugate bilirubin will not able to go into gut. Listen carefully. So this conjugate bilirubin is spill into blood. Via blood, it reaches to renal, kidney. Why? Because it is water soluble. So this bilirubin excreted in urine. That gave urine dark yellow turmeric color. Urine is turmeric color. Now conjugate bilirubin not cross the bile duct, so not reaches in intestine. So stercobilinogen not form, which is forming here, not form. That's why in conjugated hyperbilirubinemia, biliary atresia, urine is dark yellow, but stool is clay color, white stool. So classical history, this question come in another way. A neonate having jaundice, passing dark yellow turmeric urine, clay color stool. So always ask when you see a child with jaundice, clay color stool, yellow urine. It's so much yellow, mother will tell you definitely, because she can appreciate the turmeric colors. Doctor, urine is more yellow. Then immediately ask, what the stool? I find it's clay color, white stool, conjugate hyperbilirubinemia.